Hi everyone, this is the last presentation in the 4-part series. It's a quick one. During this presentation we'll be talking about a variety of medications. Don't waste your time trying to memorize doses, just focus on the rest of the information. First we're going to go over histamine antagonists and proton pump inhibitors. These are meds that are used in GI bleeding. We'll talk about antiemetics, how they work, and which ones to use when. After this, we'll cover medications that work in the lungs. And finally, we'll touch on anticoagulants, thrombolytics, and then the reversal agents for these types of medications. Let's get started.
Part of critical care is trying to prevent additional disease states from happening while they're in their critically ill state. Most famously are the patients that may develop GI bleeds during their critical care time. So there are medications that we call prophylactic medications to try to prevent things like stress ulcer prophylaxis or GI bleeds. So the most famous ones we'll use are actually histamine antagonists and proton pump inhibitors. Both of them work differently, but what they eventually do is they reduce the effects of gastric acids on stomach walls and the intestines to prevent ulcer development. Histamine 2 blockers, or H2 blockers, are selective to the H2 receptor and don't have anticholinergic effects. Theoretically, you could use an H2 blocker to potentiate H1 blockers in anaphylaxis, but the data is kind of skewed in terms of the patient populations they looked at. So a lot of times we're doing it to make ourselves feel better, but if you want a prolonged histamine blocking response, it may be worth adding on. We also have proton pump inhibitors. These suppress gastric acid secretion by inhibiting the hydrogen potassium ATPase pump. And I have two graphics here to show you how those work. Famotidine, cimetidine, and ranitidine are our H2 blockers. Esomeprazole and pantoprazole are our PPIs. Some of the clinical pearls I'd like to leave with these are famotidine really should be diluted. You can use NS if you'd like, or normal saline, and given at least over 2 minutes. Cimetidine is actually not used very often because it has a large amount of drug interactions, and then ranitidine may cause bradycardia if pushed too fast. Both esomeprazole and pantoprazole have line compatibility issues, so make sure you have decent line access if you're going to use a continuous infusion. If you're only giving an IV push or IV bolus, just make sure that you flush very well before giving the next medication. Antiemetics. I think this is every transport's professional's best friend because no one wants to deal with a puking patient in transport. Unfortunately, they all have different mechanisms and they all have different side effects, so it makes it kind of tricky choosing one in different situations. Essentially, nausea and vomiting is triggered in the medulla or the vestibular system, so knowing why your patient is nauseous or vomiting may help you in choosing your medication. If you can suppress the stimulation of the medulla by blocking the effects of histamine or the acetylcholine receptors, you may benefit from using medications like meclizine or scopolamine. These are what we would also call the motion sickness medications. So if you think someone's having vestibular issues or stimulation of their medulla, this would be one of the reasons to use those. And then we have our dopamine antagonists. They're the promethazine, prochlorperazine, and the metoclopramides. So everyone knows these as Phenergan, Compazine, and Reglan. These are pretty decent medications. Unfortunately, they do have some side effects that make it difficult to use. They can cause some extrapyramidal symptoms or syndrome, so they can have the movement disorders. It can cause oversedation, which is kind of hard if you're trying to assess your patient. And they do require slow infusion. Some people will push these, IV push these. I prefer to actually put any of these medications in a 50 milliliter bag of saline and hang them. So that way you can avoid some of these side effects.
Dopamine antagonists. So when we're talking about these receptors, what type of nausea are these going to take care of?
These medications would work really well on the, you could use them for motion sickness, but it's also things like when you have nausea and for migraines. You could use them in overdoses, but I'd be careful in overdoses because they are kind of messy in terms of their mechanisms. Let's see here. I use them pretty much on anyone who comes in with nausea. Cyclic vomiting is another good reason. And some of these medications are appropriate to use for pregnancy hyperemesis too.
So the main ones that we carry, Zofran, Benadryl, Phenergan, and Ativan, which most people don't use that as an antiemetic, but it definitely has those properties. So how do you decide, like, which one am I going to use, or when do you so badly don't want them to vomit that you just give them a bunch?
It's a good question. When I pick medications, I'm always going through all these risk-benefit ratios. I am the person that will tell you not to give medications before you do give medications. So let's kind of run through some of them. Let's start with GI bleeds. GI bleeds, they're always going to be nauseous. Blood is super irritating. The only thing that makes them not nauseous is throwing up blood. So you can sit there and give them all of these antiemetics and it's not going to matter. Then I think about things like head injuries. Head injuries, you'll have that vomiting symptom. None of these medications are going to fix the fact that they have irritating blood in their skull. The most you would actually doing is be causing more sedation and taking away their neuro exam. So when I try to pick all the other ones, I think about metoclopramide or Reglan. It's actually produces peristalsis, so you can move stuff through the stomach into the gut. So if it's just like maybe they drank too much or they have gastroparesis, I would use that medication. Compazine, I would use that for when they have migraines in particular. Phenergan kind of is our go-to for all of these. Here's the problem. All three of those, Phenergan, Compazine, and Reglan, all have QT prolongation, and so does Zofran. So if you do know your patient's QTC and it's 520, you can't use any of those medications. So that's when I'll start leaning towards Benadryl or Ativan instead. So I'm talking about ondansetron individually because it is a huge workhorse for us. And I think a lot of us would agree who've practiced for a while, we never feel like this drug actually works. It is highly specific and selective to the serotonin 5-HT3 receptor and is an antagonist. So this only works in the chemoreceptor zone of the brain. Dosing gets tricky because everyone seems to have their own sweet spot. They seem to work out for themselves. 48 milligrams is a good starting place, and you can give that lots of different ways. There's oral and sublingual and intravenous and intermuscular. You may see an order or have a protocol that says you can give Zofran every 4 hours. Personally, I think that's wasteful for a drug to be used every 4 hours because the receptors are filled. It's not like they're dropping off every 4 hours. Their length of activity is actually 8 hours. So the 6 hours is maybe so you can kind of get more drug on board before your receptors start falling off, or the drug starts falling off the receptors, but every 4 hours is a little excessive. Everyone thinks that Zofran should work instantaneously. It doesn't. It takes about 15 minutes to 30 minutes. And that's maybe one of the reasons why none of us feel like it works, because when we go to reassess our patients 15 minutes later, they're still nauseous or still vomiting. And then finally, there is QT prolongation with this drug, and it's actually being described a lot more in the literature how it exacerbates migraines. So you may want to consider taking this off your head injury or migraine cocktails. There are 3 main medications we're going to use in acute asthma and COPD exacerbations. Albuterol is a beta-2 agonist that induces airway smooth muscle relaxation, leading to bronchodilation. Remembering that beta-2 is for 2 lungs to help you remember what agonist it is. The dose is 2.5 to 5 milligrams every 20 minutes until you're having relief of symptoms, or you may actually have a continual nebulization of 10 to 20 milligrams per hour. If you're lucky enough to have a respiratory therapist as part of your team, they just intuitively know which route to go, it seems. The problem is although it is a selective to the beta-2 receptors, it still causes a significant amount of beta-1 activity. You're going to see this resulting in tachycardia, and therefore your patient will become a lot more anxious. So that may be a rate-limiting step for you to use this medication in large doses. Another medication we'll use a lot is ipratropium. We use this more for COPD patients than asthma. It is a inhibitor of the cholinergic receptors on your bronchial smooth muscles. The dose is 0.25 milligrams every 20 minutes for 3 doses, or if they get relief of symptoms sooner, you may not have to do that 3rd dose. And then finally, there's corticosteroids. It seems like every doc has their special steroid they like to use, but essentially it's going to reduce inflammation in these exacerbations, and it will provide a longer duration of relief for a patient. Now, here where things get complicated. There are pulmonary medications you may see that are used to treat and manage life-threatening pulmonary conditions. These would include pulmonary arterial hypertension, refractory hypoxemia, or ductal issues in the neonate. Epoprostenol is a vasodilator, prostaglandin, and prostacyclin and also an inhibitor of platelet aggregation. Lots of mechanisms to essentially say we're going to treat severe pulmonary arterial hypertension, or PAH, and we'll actually use this sometimes in acute right heart dysfunction. It's an intravenous continuous infusion that you may see in transfer. It can also be nebulized, but I can't imagine doing that in a transport situation. The dosing is 2 nanograms, not micrograms, not milligrams, nanograms per minute. And it's very, very gradually titrated in increments of 1 to 2 nanograms at a time. And I'm not talking like every 15 minutes. I'm talking like every few days. It's very limited titration because the patient exhibits side effects that are intolerable, so flushing, headache, and hypotension. Now, there's a cousin to this drug called treprostinil, and patients actually live on this and a continuous pump on the outpatient side. So you may come across a patient with this pump running. The only thing I ask is do not stop that pump. It is very important to continue therapy unless there's specific reasons, like they're profoundly hypotensive. The reason is the minute you take this off, and I literally mean the minute you stop this drug, their pulmonary hypertension rebounds, and you can be in a really bad oxygenation situation. Alprostadil is another prostaglandin and vasodilator. We use this mostly for the patency of ductus arteriosus in neonates. It's pretty much only used as a bridge from to a surgical intervention, like a transplant or some kind of surgical correction. This is also a continuous infusion, and it's titrated very slowly until clinical improvement is seen. The biggest clinical pearl I'll leave about this drug is that 10% of neonates will have a scary amount of apnea on this medication, and it's usually seen within the first hour of starting the drug and in very low neonates. If that happens, it doesn't mean they fail the drug. You would stop the infusion, let them recover to their baseline, whatever that was, and then restart at half the rate. Racemic epinephrine is actually used in a lot of situations, but maybe inappropriately. So kind of understand where you would use this drug if you need it. It has both alpha and beta agonism. The alpha adrenergic side helps with mucosal vasoconstriction, so that will decrease fluid and edema in your airway. And then the beta side will help with the relaxation of the bronchial smooth muscles. This medication could be used for like extreme stridor, epiglottitis. I've seen it occasionally in angioedema, but doesn't seem to really help. Sometimes they actually exacerbate their anxiety and make their angioedema worse. Anticoagulants, thrombolytics, and reversal agents are really bread and butter drugs for pharmacists. We get really excited about these. So when you come in with a patient with these, we're going to be really interested on this process and when you come in. So during transport, it might be medically necessary to continue or initiate anticoagulation or give thrombolytics. Indications, there are a lot of them. Pulmonary embolism, MI, ischemic limbs, peripheral artery occlusions, ischemic strokes, and STEMIs. Anticoagulants actually work by preventing or slowing of clot formation, whereas a thrombolytic is the dilution of a clot. Some people call them clot busters. You really should know the labs that the patient had and the risk for bleeding before initiating these. Heparin potentiates the inhibitory effect of the antithrombin 3 enzyme on factor 10A. So it inactivates thrombin. Because the thrombin enzyme is not available, fibrinogen can't be cleaved to fibrin, which is insoluble, and fibrin is what actually works to make clot formation. There are probably hundreds of different dosing protocols for heparin. My recommendation would be obtain the dosing protocol for transport. If they can print you off a version or screenshot it, that'd be great. Most times there's a bolus and a drip. We may not bolus a patient depending if they have a history of liver failure or they already have an elevated APTT. Please don't give this medication to patients with history of heparin-induced thrombocytopenia. That's a lifelong contraindication. And patients with liver failure who already have a high risk for bleeding may have a higher risk for bleeding when you add on heparin. That being said, there are going to be liver patients who need heparin, and it's a risk versus benefit and a very delicate balance in terms of dosing. Alteplase and tenecteplase are both what we would consider clot busters. They directly convert plasminogen to plasmin and then degrade a clot-bound fibrin. There are very specific indications for each one of those medications based on the amount of medical literature. There are some institutions that will use them interchangeably, so you may not match your normal education. So they can be used for acute ischemic stroke, massive pulmonary embolism, STEMIs, or acute peripheral occlusions. Alteplase is weight-based bolus and then a drip, or in the case of a massive pulmonary embolism or someone who's having a cardiac arrest because of pulmonary embolism, it may be a set dose. And then tenecteplase is only a one-time weight-based bolus. They have almost immediate onset and they can last almost 2 hours. That being said, the bleeding risk can be seen for the next 24 hours. The 2B3A inhibitors are used to bridge to percutaneous intervention or a stent in the cath lab. They're indicated in patients who have acute coronary syndromes or an NSTEMI that may be delayed going to the cath lab because they're not as acute. They work to decrease platelet aggregation by reversibly antagonizing the binding of fibrinogen to the glycoprotein 2B3A binding site. To the right is a picture that kind of explains that a little bit better. What you're doing is making it so that your platelets don't adhere to each other. Dosing strategies are going to vary for these also, so obtaining a dosing protocol for transport may help. Some of these drips only run for 18 hours and some run for 48 hours, depending on the disease state and if they made it to the cath lab or not. Now we're going to talk about some reversal agents. Protamine is a very strong base that actually binds with heparin to prevent its action.
Protamine or salmon sperm?
It is both.
Okay, I was just checking.
That's how the drug is made, is from salmon sperm. Now, unfortunately, protamine has very limited reasons to use it because your heparin will actually degrade faster than you can get protamine on sometimes. So it's indicated when heparin reversal is emergent. They're bleeding and they have elevated ACT or APTT, or sometimes there's an accidental administration, someone that we're worried about they would have a high risk for bleeding. Let's say they just had spine surgery yesterday and someone accidentally got heparin. Timing since the last heparin dose exposure depends on whether or not what dose you're going to use, and then it's very weak, but you can use it on enoxaparin. So the dosing is as follows. Heparin reversal is 1 milligram of protamine to every 100 units of heparin. But if it's been at least 30 minutes since heparin has been given or you've turned off the drip, it's only a half a milligram to 100 units of heparin. We can also use it for enoxaparin reversal. It is not complete and it's not neutralized. So it would be 1 milligram to every milligram of enoxaparin. Here's the tricky part. If the heparin's already metabolized and you waited 3 hours to give this protamine, the compound doesn't have anything to work on. And it's actually a weak anticoagulant by itself. So you could cause bleeding because you didn't give it in time.
So timing is of the essence.
I don't give this medication if it's not within 30 minutes of heparin exposure. Vitamin K, also known as phytonadione, but we're going to just call it vitamin K because that's easier for everyone. It is indicated for impaired coagulation functionality and liver failure. So you may see someone get vitamin K, a certain dose every day for 3 days, for example. Or you can use it for warfarin reversal because warfarin is a vitamin K antagonist. You would use this as an IV administration only because there's a faster onset of the drug. But really, there's the same outcomes as orals at 24 hours. The dose is really going to be dependent on the bleeding and the INR level, or the international ratio for how fast or slow someone's blood clots. It may be given in combination with FFP, so don't be surprised if you're giving two things to reverse. And then we do ask you to infuse this very slowly because it can cause an anaphylactoid-like reaction. So anything from hives to hypotension.
So an anaphylactoid is basically an anaphylaxis reaction, but it happens through a different mechanism, correct? It's not the histamine release.
Correct. And we may not always know what that mechanism is. It could even just be irritation of the veins. So we don't always know what the reaction would be, but anaphylactoid is like an anaphylaxis, but not anaphylaxis. PCCs are also known as prothrombin complex concentrates, are medications that we use to reverse drugs like warfarin or potentially the new novel oral anticoagulants like dabigatran, Xarelto, rivaroxaban, Eliquis. So those are very hard drugs to reverse. These drugs are actually a group of clotting factors, specifically for Kcentra, 2, 7, 9, and 10, and they also have antithrombotic protein CNS. And those become deficient when patients are on warfarin or a novel oral anticoagulant. Another indication may be in patients who have massive bleeding and they have a disruption of their clotting cascade. And you would know that they had a disruption of their clotting cascade because of lab tests like ROTEM or TEG. Dosing is going to vary based on the drug we're trying to reverse. if the patient's on warfarin, their INR level, and the weight of the patient. This is a 14-step reconstitution process and requires refrigeration before being used. So if someone just hands you the box for transport, tell them no. There's no way you're going to do a 14-step reconstitution process when you're trying to care for a patient. And it's also incredibly expensive. We're talking a $30,000 charge to the patient. The risk factors of this drug, other than wasting drug and making your pharmacist very angry, is that it could cause thromboembolisms, so a VTE such as a DVT or PE. And we recommend, and the literature recommends, to not give it if the patient's already received FFP and vitamin K. By adding a drug on like Kcentra after giving FFP and vitamin K, you can actually make it very possible for them to have a massive PE or DVT. TXA, or tranexamic acid, this is a drug that actually inhibits activation of plasminogen. So therefore, the plasminogen conversion to plasmin cannot happen. We use this drug for massive traumatic hemorrhage, life-threatening uterine bleeding, and hyperfibrinolysis, or your clots are breaking down because the fibrin cannot stick together.
All right, that does it for our pharmacology section. A lot of these meds you will continue to see us talk about throughout this course. A big thanks to Erin for sharing her expertise with us, and we'll see you on the next one.